or good afternoon to the audience. And as Apostolos was saying, I am based at Erasmus University, Rotterdam, and I'm presenting from a professional studio here at the Erasmus University campus. Our topic of today is multi-criteria decision analysis of integrated care. And I will focus on the methods that we have used in the SELFIE-project. But first of all, I would like to thank the International Foundation of Integrated Care for the opportunity to talk about MCDA with the members of IFIC. So I'm very much looking forward to hearing your views and thoughts and questions and ideas afterwards. But let's get started. Like I said, we're going to talk about the MCDA methods that were used in the SELFIE-project. SELFIE is an Horizon 2020 project, and this is the usual disclaimer of these types of projects, stating that the content of this presentation does not reflect the view of the European Commission. SELFIE is about sustainable integrated care models for people with multiple morbidities. It's about delivery, financing, and performance. And in the first presentation I made, I had a couple of slides explaining multi-morbidity and the problems that persons with multi-morbidity are facing in navigating through the health and social care system. But I deleted the slides because you as members of IFIC are very well aware of the issues that persons with multi-morbidity have to deal with. So we can immediately start with SELFIE and MCDA. SELFIE has 5 aims, like I listed here in this slide, and I hope everybody can see it very well. Today we'll focus especially on the third aim, which is about providing empirical evidence about the impact of integrated care programs on outcomes using multi-criteria decision analysis. What is MCDA? MCDA is an umbrella term for a series of methods to aid decision-making that is based on more than one criterion, in which the relative impact that each criterion has on the decision is made explicit. MCDA offers a means to consider a comprehensive set of sometimes conflicting decision criteria. And by conflicting, I mean that some decision criteria may favor the integrated care program, whereas other decision criteria may favor the comparator. MCDA explicitly engages the stakeholders in a dialogue about what are the most relevant decision criteria and the importance of the criteria for the decision at hand. MCDA is particularly suited to study the complexity of integrated care programs for multi-morbidity and for evaluating them. Because as you know, integrated care programs usually consist of multiple interacting interventions in the same program. They target multiple levels, for example, individual patients, but also groups of providers or organizations or even entire healthcare systems or social care systems. And context always matters. The context in which the programs are implemented continuously interacts with the integrated care initiative itself. There's always a variety of outcomes, which we usually group in the triple aim, like improving health and well-being, the first aim, improving the experience with care, the second aim, and improving or reducing the cost or the cost increase. And as members of IFIC, you're very familiar with the triple aim. And of course, the outcomes are impacted by both the behavior of those delivering the integrated care initiative and those receiving the interventions. And through the way, over time, the programs are usually continuously adapted and improved. Just to illustrate the complexity of integrated care programs, and especially for people with multi-morbidities. So we argued, when we are moving from towards a more person-centered, integrated approach of caregiving, then we also need to adopt a more comprehensive, inclusive form of evaluation. So we need to adopt a more holistic, person-centered understanding of what value is when we evaluate the added benefits of integrated care. there is more to value than health. Coming from my health economic background, I am arguing that the quality adjusted life year metric might not be sufficiently broad enough to capture all the benefits of integrated care initiatives. Doing an MCDA usually contains 7 steps. The first step is understanding the integrated care initiatives under evaluation and the decisions that need to be informed. The second is to identify and structure the decision criteria. The third is to determine the performance of the integrated care programs on these criteria. Next step is measuring the importance, so the weights of the criteria. And then in the 5th step, an overall value score is created by combining the weights with the performance scores. And step 6 and 7 is doing sensitivity analysis and discussing the results with the stakeholders. I will walk you through these 7 steps. More details about the 7 steps of MCDA can be found in this paper, which was published last year in Health Services Research, explaining the methods of MCDA in the SELFIE-project. Let's start with the first step, understanding the integrated care programs and the decision context. In the SELFIE program, we selected 17 different integrated care initiatives across 8 countries: Norway, the UK, Netherlands, Germany, Austria, Hungary, Croatia, and Spain. 17 promising integrated care initiatives. And we grouped them into 4 different categories. We had population health management programs, frail elderly programs, programs for people with problems in multiple life domains, not only health problems, but for example, financial problems, housing problems, addiction problems, unemployment, things like that. And we have problems which specifically focus on patients who need palliative care or patients who have cancer. So 4 groups of programs. And the decisions about these programs that need to be informed by the MCDA usually somehow relate to the sustainability of these programs. Either there's discussion about their reimbursement, about whether or not to continue the programs, about extending them and implementing them in a wider region. So that's what we are aiming with the MCDA, to inform these types of decisions. In the first step, we did qualitative research. We did document analysis and held interviews with many different stakeholders. And this resulted in so-called thick descriptions. In these thick descriptions, we described the hard facts of a program, like, for example, the services provided, the professionals involved, the contractual arrangement, the funding, etc. But we also try to go beneath the surface and describe the soft facts, like the culture in an organization, the social relationships between professionals, the power relationships between the people involved, etc. The thick descriptions of all 17 programs are available on the SELFIE website, so you can read the full details there. Each thick description was grouped by the SELFIE framework of integrated care for multi-morbidity. And I know you can't read this framework. That's not important. What's important to understand is that the framework has 6 different components: service delivery, leadership and governance, workforce, financing, technologies and medical products, and information and research. And within each component, we have 3 levels: the micro level, the meso, and the macro level. So each of the 17 programs is described in terms of these 6 components and the various levels in the components. The framework itself is published in Health Policy last year. An important part of the first step is identifying the stakeholders who are involved in the decision-making process. And in the SELFIE-project, we identified 5 different groups of stakeholders. First of all, the patients with multiple morbidities, then their partners or other informal caregivers, the professionals, so the care providers, and the payers and the policymakers. Those are the people whose opinions count in this decision-making process. In the second step, we need to identify and structure the decision criteria that will be included in our MCDA. And in the SELFIE-project, we defined a core set of 8 criteria, which we grouped by the triple aim. In the health and well-being domain, we included physical functioning, psychological well-being, social relationships and participation, enjoyment of life and resilience. And we measured experience with care, with person-centeredness and continuity of care. And we calculated the cost of the 17 programs. For each of the outcome measures, we selected domains of existing validated questionnaires to measure the outcome. In addition to our core set of outcomes, we also had a couple of program type specific outcomes, like for the frail elderly programs, we measured autonomy, and for the population health management programs, we measured patient activation. Just examples. We selected these criteria, or the process of selecting them was driven especially by the focus groups that we held with persons with multiple morbidities. We did that in each of the 8 countries participating in SELFIE. And we talked with the patients about what good health and good well-being meant to them and what a good care process meant to them. The results of the focus group are published in BMJ Open last year. We also held national workshops with representatives of the 5 Ps in each of the 8 countries. And we looked at the outcomes that were already measured in the 17 programs, because all of them were ongoing initiatives. And we did, of course, a literature review of the outcome measures for integrated care. And all of this resulted in a very long list of potential outcomes, which we shorted into the core set using various criteria. But an important criterion was preference independence, meaning that we can measure the preference for a certain criterion independent of the performance on other criteria. So measuring or weighting them should be independent from the performance on other criteria. After having identified our outcomes, we started measuring them in the empirical evaluation studies of the 17 programs. And we designed 17 different quasi-experimental studies comparing an intervention group that received the integrated care intervention and a control group that had usual care. And to give you some flavor of the various types of control groups that we included in the SELFIE-project, I created this table because you probably all know how difficult it is to find appropriate control groups for an integrated care initiatives. So, for example, for the Care Chain Frail Elderly program, we designed a quasi-experimental prospective evaluation, did propensity score matching, but the intervention group consisted of patients that were recruited from general practices of 3 care groups that had already implemented a bundled payment program for frail elderly. And the comparator patients were recruited from GPs from one of the same 3 care groups, from one of the care groups that not had implemented the program yet. So the patients in the intervention group came from the GPs of 3 care groups, and the control group from the GPs from 1 care group that not yet had implemented the intervention. That's one example of a comparator group. In another program, Better Together in Amsterdam North, which is a program for the patients with problems in multiple life domains, we identified the intervention group included individuals with limited self-sufficiency that were referred for participation in the Better Together in Amsterdam North program. But the control group subjects were difficult to identify. And we were lucky that there is an ongoing monitoring questionnaire, the Amsterdam Health Monitor, that's held every 2 years, from which we could identify individuals with a similar type of limited self-sufficiency to serve as the control groups. And in both of these programs, individual patients were visited at home to be interviewed. In the first program we did it ourselves, and in the second program that was done by TNO, a research organization with whom we have collaborated. Another example of a care group was for the palliative care program, the multidisciplinary specialist palliative care team, the mobile team, that provides palliative care in Croatia. It was also a prospective study, and the palliative care patients came from 3 counties in Croatia, so 3 regions. And the control patients were similar patients obtained from 3 different countries that not yet had implemented mobile palliative care. And my last example comes from the UK, the South Somerset Symphony Programme, which was a retrospective quasi-experimental study with a difference in difference analysis in which they obtained the outcomes from routinely administered questionnaires and other types of data sources. The experimental group consisted of the entire population of 1 clinical commissioning group that offered the program, and the program included complex care hubs of the GPs in the hospitals and a co-location of health coaches or lifestyle coaches in GP practices. So the intervention group was from 1 clinical commissioning group, and the comparator group was the entire population of England or the population living in another geographical region or another time period. So just to illustrate the efforts we went through to define control groups for each of the 17 evaluations that we conducted. And then we started measuring the outcomes. And as you had seen on some of the previous slides, outcomes are measured with different instruments. Like here, the experience with care outcome, person-centeredness is measured with P3-SEC, and continuity of care is measured with other questionnaires. And obviously, the scales of these questionnaires differ. So before we can combine the various outcomes into an overall value score, the first thing we need to do is to standardize the outcomes of the different scales into a similar scale. And that is what is shown in this table, where we standardize the P3-SEC scores and the NCQ plus CPCQ scores into standardized scores with the relative standardization formula that I've listed here. I will not go into the details of this formula. You can read it afterwards if you like, but it's important to understand that after measurement, we need to standardize the scores to use them in the MCDA process. So we have now designed the evaluation studies, started measuring the outcomes, but we also need to obtain the weights, the important weights for the different outcomes. So we conducted a weight elicitation study among the 5 groups of stakeholders that we had identified, the 5 Ps. And we had a recruitment target of 150 respondents per P in each country. So we did an awful lot of weight elicitation questionnaires to obtain the weights for the core sets of outcomes. How did we obtain the weights? We conducted a so-called discrete choice experiment. And in a discrete choice experiment, respondents are given a choice between 2 different programs, Program A and Program B. And these programs are described in terms of how well the participants perform on the 8 core set outcomes. So there's a difference in performance on the outcomes between Program A and Program B, and we asked the respondents, which program do you prefer, A or B? And each respondent gets many of these DCE questions, 18 altogether. And using choice modeling, regression modeling, we can infer the important weights from the answers that the respondents give to these types of questions. So by looking at the frequency with which they choose either program A and B and the characteristics of these programs, we can determine the weights that are given to the various outcomes in our core set. That is, in a nutshell, a very short explanation of a discrete choice experiment to obtain weights. This table shows the definition of the core set of outcomes that we used in the discrete choice experiment. It was an online questionnaire, and when respondents moved the mouse over the name of an outcome, then these definitions appeared. So to make sure that the interpretation of the outcomes was a bit standardized across the respondents. This bar chart shows you the results of the weights that we measured in the Netherlands among the patients, so the first P, the patients. And as you can see, within the health and well-being domain, the highest weight was given to enjoyment of life, followed by psychological well-being and physical functioning. The lowest weight to social relationships and participation. Within the experience domain, we had person-centeredness and continuity of care, and the weights assigned to these two outcomes were a bit lower than to some of the health and well-being outcomes. And the lowest weight was given to total cost, which is understandable from a patient's perspective, of course. So we have now measured the outcomes in the empirical evaluation studies. We have obtained the weights, and in step 5 we combined the two into an overall value score using a linear additive model. So we measure the performance, we obtain the weights, and we combine them two in an overall value score for integrated care, for the integrated care group, and we do the same for our control group, our usual care group. So we have two overall value scores that we can compare. We do this process 5 times. Once with the set of weights obtained from the patients, and then we repeat this with the weights from the partners or other informal caregivers, etc., etc. I'll show you how that is done. Here you see the weights that we obtained from the patients, similar as I showed in the bar chart. And next to that, the weights obtained from the payers. And as you can see at the bottom, the costs are having an almost 2 times higher weight by the payers than by patients, and they gave a somewhat lower weight to resilience, but otherwise the weights that were given by payers and patients were not that much different. Okay, next step is to combine the performance scores and the weights. And I show here one example for psychological well-being. I take the standardized score as we measured for psychological well-being in the empirical evaluation study, which was 0.77 for the integrated care group and 0.64 for usual care. And I combine that with the weight that patients assign to psychological well-being. So 0.77 times 0.17 gives 0.13. Likewise for usual care, 0.64 times 0.17 gives 0.11. And we do that for all the outcomes in our core set. So in this example, which is a hypothetical example, you see that the integrated care program performs better on all outcomes except for health and well-being, for physical functioning, which is a bit lower in terms of scores than usual care, and also in terms of costs because the program is more expensive than usual care. And for each of the outcomes, we combine the standardized performance scores with the weights, we multiply them to get a partial value score. And when we sum up all the partial value scores across the 8 outcomes, we get a total value score at the bottom of 0.71 for integrated care and 0.59 for usual care. So the overall value of the integrated care initiative, taking into account our 8 outcomes, is higher than usual care in this example. And we can repeat this same process with the weights of the payers, like I did in this table. Same procedure, leading to an overall value score of 0.68 for integrated care and 0.57 for usual care. And we can do that from multiple perspectives, so using the weights from each of the 5 groups of respondents separately in the MCDA. In the SELFIE-project, we made a multi-criteria decision analysis tool that we put on the website of the SELFIE-project for other people outside of our project to make use of the weights that we have obtained in this project. This tool does the entire calculation of the MCDA table, starting from the standardization of the performance scores to the final table of the MCDA results. The tool contains the weights from all countries in SELFIE, so other people can use these weights and combine them with the performance scores they have measured themselves on similar outcomes to our core set. So feel free to use that and have a look at the calculation tool, and feel free to email questions to us about this. Okay, that brings me to step 6, doing sensitivity analysis on our MCDA results. We can do deterministic sensitivity analysis. For example, instead of using the DCE weights, we can use weights obtained with another method. We did swing weighting in SELFIE as a second method, which I'm not going to explain, but you can read it in the MCDA paper. Or we could use another method of standardization instead of the relative standardization of the performance scores that I explained. And besides the deterministic analysis, we can of course also do a probabilistic sensitivity analysis to process the joint uncertainty in the performance scores and the weights and take into account that joint uncertainty. We can also address uncertainty in program costs separately and the size of the target population, for example. By doing so, you may know, in cost-effectiveness analysis, we commonly address the uncertainty in a CE plane and show the results and the uncertainty in a cost-effectiveness acceptability curve. We can do something similar here and draw what we called in SELFIE a so-called conditional multi-attribute acceptability curve. On the horizontal axis of this curve, you see the budget that is available for a given size of the target population of the integrated care initiative. On the vertical axis, you see the probability that the integrated care initiative is found acceptable. And acceptable is defined as having an overall value score that is higher than the comparator group and at the same time keeping within the budget. So making sure that when I multiply the size of the target population times the mean cost of the program, that total remains below the available budget. And doing Monte Carlo simulation, I can calculate the probability, the likelihood that the integrated care initiative meets these 2 criteria and is found acceptable. So that is a means of showing uncertainty in multi-criteria decision analysis results. Brings us to the last step in the MCDA, which is the interpretation of the results and the discussion about it with the representatives of the 5 Ps. Because the beauty of the method is that they are involved in several steps and we can show them the results from every step separately and the combined overall result and discuss that between the groups of the 5 Ps. Okay, so much for the process of obtaining the overall value score. Let's now discuss a little bit about strengths and weaknesses of MCDA. I think one of the strengths is that we have better informed decision making. We inform decision making not only about the performance on a wider range of outcomes, but we also weigh these outcomes. And we do so even from multiple perspectives, so we look at the same problem from multiple different viewpoints. That should improve the transparency, consistency, and accountability of decision-making of integrated care overall. Like you saw in my example, we included costs in the core set of outcomes to make sure that costs are traded off against other criteria in the analysis, to make their relative contribution to the decision-making process explicit. But that is debated, as I will show you on the next slide. But first, one of the more often mentioned weaknesses of MCDA is that we are somehow creating a new sort of composite measure of benefits that might not be that comparable across diseases and interventions as a quality-adjusted life year. And that's, of course, true. We can compare the overall value scores across the 17 integrated care initiatives in the SELFIE-project because we use the same methodology and the same types of benefits that we included in the overall value score. But it is less comparable, perhaps, across other areas. And we also realize that because we trade off costs against the other criteria, that we don't have the opportunity costs of one additional unit of that new composite measure of benefit, which in a traditional cost-effectiveness framework we would need to have. In that framework, we would measure the benefits in a broad sense and then compare that new composite measure of benefit to the costs for having one unit of additional benefits. So we don't have a threshold like we have for quality-adjusted life years. Another weakness might be that we are using one weight for each outcome measure, irrespective of the place on the performance scale. What I mean is that the weight is the same irrespective of whether we are measuring at the good end of the scale or the bad end of the scale, or whether the improvement is on the upper end or the lower end. So there might be, we need more information on this connectivity between the performance scale and the weight, and we are looking into that further in the SELFIE-project. And we can also discuss further about using additive models and whether that is most appropriate, yes or no. So that's a bit of discussion of strengths and weaknesses. Brings me to the conclusion for today. MCDA is, in my view, a mixed methods approach that has great potential to improve decision making about the implementation of integrated care, and also to inform value-based payments. This is really one of the first attempts to truly measure a broad range of benefits and integrate them into one value score. And the methods and also the weights that we have applied in SELFIE can be used by other stakeholders in future evaluations and monitoring studies of integrated care, if they measure outcomes that are conceptually similar to the ones that we have included in our MCDA analysis. I will use this opportunity to draw your attention to the closing conference of the SELFIE-project, which is held in Amsterdam on June 13, and I've projected the program here. During this conference, we will present the final results of the MCDAs of various of the programs that we have evaluated. We will present all the weights from the different countries, and we will also present, for example, results from the empirical evaluations that we did of a few payment reforms to stimulate integrated care. It's a very promising program, and you're warmly welcome to attend the program. It's free of charge. The only thing you have to do is to register at the SELFIE website. I think I'd like to finish my presentation here. Thank you for listening to me, and I've hoped that I've raised your interest in MCDA.